So thank you for having me. To get us oriented on ADHD, I'm going to be providing some background on ADHD in children with Down syndrome. Before that, for disclosures, I have funding from NICHD and a contract with Lumind IDSC. And to get us oriented, I wanted to go over the diagnostic criteria for ADHD from the Diagnostic Statistical Manual, the 5th edition. According to the DSM, what we require is over the last 6 months, we have a persistent pattern of concerns with inattention and hyperactivity or hyperactivity that interferes with functioning. And there's 9 symptoms for each of inattention and hyperactivity. And what we require is that the child meets at least 6 of those criteria if they're up to the age of 16, and then 5 if they're older. And these symptoms have to be inappropriate for the child's developmental level and disruptive. They also need to be present before the age of 12 and present in 2 or more settings. So not just at home, but also with school or friends or in other activities. And they have to reduce or interfere with the quality of school or social or work functioning. There's 3 different types. We could have inattentive presentation, which is 6 or more of those symptoms of inattention. Hyperactive impulsive presentation, which is focusing more on those 6 out of 9 symptoms of hyperactivity, or combined when you have 6 symptoms in both areas. Now, to orient all of us onto the symptoms that we're looking at, these are the 9 symptoms that are screened for inattention. And if you're looking at this from the lens of Down syndrome or intellectual disability, you might sort of question to be like, well, you know, is that ADHD or is that an intellectual disability? So often has trouble organizing tasks and activities. A lot of us in the field will provide supports for children in terms of organizing. So how do we assess that? What's ADHD versus what is maybe attributed to Down syndrome or their level of functioning? But I'm not going to read all these symptoms. I just want you to have them to sort of orient everybody to what these symptoms are. Here's the 9 symptoms for hyperactivity. And if you'll have a look at these are a little bit easier for us to see or identify, to be able to differentiate what's Down syndrome versus what's, talking excessively. We'll be able to more easily generally identify some of these hyperactive symptoms. But when you're looking at those inattentive symptoms, there's probably a little bit of that diagnostic uncertainty, be like, what's related to intellectual disability, what's related to ADHD? So how do we accurately diagnose ADHD in kids with Down syndrome? This term is referred to as diagnostic overshadowing, where we attribute symptoms of mental health conditions, so in this case ADHD, to their intellectual disability. The Diagnostic Statistical Manual, or the Diagnostic Manual for Intellectual Disability, has now come out with a 2nd edition, which is a companion book to the DSM to be able to support making diagnoses in individuals with intellectual disabilities. And so for some conditions, there are recommended adaptations or changes to the diagnostic criteria. For ADHD, what the DMID recommends is that we use the same criteria and thresholds for identifying ADHD in kids with intellectual disability as we do in kids who are typically developing. However, we need to make that comparison in terms of symptoms to peers of comparable intellectual and chronological age. So that puts a lot more pressure on the clinician to be able to have a cohort of peers with Down syndrome or with intellectual disability to be able to make that comparison to say these symptoms are more severe than what we'd expect for their developmental level and their age. The good news is that people have been looking at ADHD in kids with intellectual disability for a long time and have established that it is a unique construct within intellectual disability. So they've done that multiple ways. One way they've done that is they've looked at hyperactivity and symptoms and looked at that in factor analysis with other behaviors, and they found that hyperactivity falls out as a unique construct in these factor analyses with other behaviors in both adults and children. They've also done comparisons within individuals with ADHD, both typically developing and with intellectual disability, and found that there were similar psychological characteristics that were falling together or that were appearing in these 2 groups of individuals with ADHD. They've looked at within individuals with intellectual disability and comparing those with and without ADHD, and found that there was definitely a distinct pattern of activities and behaviors and attention problems in those 2 groups. So within kids with intellectual disability, there was differences that were observable for those who did and didn't have ADHD. And there's been a very large literature on the use of stimulant medication and clinical trials in children with intellectual disability and ADHD. Now, if we're looking at the rates of ADHD, if we're looking just at the literature, so these blue bars, what the literature is suggesting is that the rates of ADHD in kids who are typically developing is about 8%. It's higher in kids with intellectual disability. It's higher in parent reports of kids with Down syndrome. And it's even higher if we look at clinical interviews with the parents of kids with Down syndrome. So again, this blue bar here would suggest that there's a genetic or the Down syndrome diagnosis confers a specific risk for ADHD. But if you're looking at those green bars, this is from the National Health Interview Survey. It might suggest a contrary pattern of findings. Individuals with Down syndrome and intellectual disability still have a much higher rate of ADHD than kids who are typically developing. But here, the individuals with Down syndrome have a lower rate than their peers with intellectual disability. So whether or not we think there's a genetic risk or whether or not we think there's contrary findings, I think we can agree that the reports in the literature and in national surveys is suggesting that the rate of ADHD in individuals with Down syndrome is about 10 to 45%, which is still alarming when we're looking at the rates in the general population. Something that we need to consider, though, is how we're making those diagnoses. So the prevalence of ADHD could depend on the method of diagnosis that we're making, and the method of diagnosis has been variable in the literature. The literature that is using the Diagnostic Statistical Manual is pretty consistent between 30 and 45% as a reported prevalence of ADHD in individuals with Down syndrome. The rates are a little bit lower when we're looking at just rating scales. So when they were just looking at parent reports on ADHD screens, they're finding rates of about 25%. But again, remember the criteria that we have to have symptoms across 2 settings. And so when they looked across 2 settings with, again, parent and teacher reports, the rates went down to about 12%. So still all these numbers are within that 12 to 45%, but you're seeing how different use of the Diagnostic Statistical Manual or parent ratings can vary those prevalence estimates. In our own pilot data, we've looked at parent reported diagnosis of ADHD in terms of something that was in their medical record. So a clinician had diagnosed it at some point, and so that's where we're seeing about 18% of kids with Down syndrome are reporting a diagnosis of ADHD. And then in our data, when we were looking at both parent and teacher reports across those 2 settings to be able to make a clinical diagnosis, we were actually finding a much higher rate, about 40% of kids were meeting criteria. So suggestive that we might be underdiagnosing in the clinical setting what we're seeing on rating scales. So maybe we're not always identifying every child with ADHD. When we're looking at ADHD, we also need to consider how it may vary by demographics. In kids with intellectual disability, ADHD symptoms worsen with age and are more common in boys. There's been no correlation found with cognitive skills or daily living skills. Within Down syndrome, there's, again, take this with a grain of salt, there's very few studies. There has not been a supported relationship with age. However, individual symptoms might worsen with age, but again, not all of them. Ourselves and others have not replicated that a gender difference, which is also present in the kids who are typically developing. There is that boys having more symptoms in the general population. We corroborate that there was no correlation with cognitive skills, but there's been inconsistent findings in terms of a relationship with daily living skills. And then others have found a relationship with vision concerns, which is interesting, but then it becomes the question of, again, how good are we at making the diagnosis? Is it that the children was inattentive or they couldn't see the material, and so then they looked like they weren't paying attention because they couldn't see and interpret the material presented with them? So it's really important that we consider other conditions when we're looking at ADHD. In our own pilot data, we've got about 44 kids with Down syndrome and ADHD, and 64 who don't meet criteria. And we didn't replicate any findings in terms of group differences with vision concerns. So both groups were having about comparable levels of vision concerns in the 2 groups. But we did find other conditions where there were differences. Our children with ADHD had more concerns for allergies, had more concerns for sleep problems, and had more diagnosis of disruptive behavior disorder. So again, demonstrating, how much are the sleep problems contributing to, difficulties with being able to pay attention, how much are allergies contributing to challenges with paying attention. So there are other conditions that are warranted to be examined when we're looking at diagnosing ADHD and how they're contributing to the symptom presentation. So then treatment, what are we going to do with these kids with Down syndrome that are presenting at these higher rates than in the general population? So in the typically developing population, the evidence-based treatment is to have both medication and behavioral treatments be used, so that multimodal treatment plan. The effect sizes for medication-related improvements in ADHD symptoms are large, so when we use medication, it's beneficial, and the majority of kids respond positively to stimulants. In kids who have intellectual disability, there's been several clinical trials of methylphenidate trying to improve symptoms of ADHD, and still 75%, up to 75% of kids have been considered beneficial responders, but you'll see that there's also that lower rate, so maybe not all kids are responding as positively. But the consensus guidelines recommend using stimulants as a first-line medication treatment for children who have intellectual disability and ADHD. However, it should be noted that the majority of these clinical trials actually excluded kids with Down syndrome from the trial because we wanted to have a pure sample, or they didn't state whether the participants had Down syndrome. In personal communications with some of the primary investigators, they would indicate that maybe 2 of the children in the study had Down syndrome, so not enough to be able to go back and look at the data to report on any specific findings for those children. So when we look at the rates of stimulant use in kids with Down syndrome in the National Ambulatory Medical Care Survey, this was comparing kids with typically developing kids and also kids with Down syndrome, you're seeing a much lower rate of medication use in kids with Down syndrome. So alarming given that the prevalence of ADHD is higher in kids with Down syndrome than in the typically developing population. And similarly, in the National Survey for Children with Special Health Care Needs, they also found a disparity where kids with Down syndrome were receiving medication at a much lower rate than their peers with intellectual disability. These are some other studies that were in the literature, and these were the reported rates of medication use for kids with Down syndrome. So again, if we're looking anywhere from 4 to 9% of kids with Down syndrome receiving stimulant medication, that's much, much lower than the up to 45% of kids with Down syndrome potentially being diagnosed with ADHD. And there are legitimate reasons for why physicians might have concerns with prescribing medication to kids with Down syndrome. Our kids with Down syndrome have a much higher risk of having a congenital heart defect. And for individuals with or without Down syndrome who have a congenital heart defect, there is a concern for sudden cardiac death when taking methylphenidate. So the recommendations for children with congenital heart defect are that we get an EKG for some or all children prior to prescribing methylphenidate, but the stimulants can safely and effectively be used to treat ADHD. And so much so that the American Heart Association states that it's reasonable to consider using stimulant medication in children with congenital heart defects. So, we're worried, but you can use it. You just want to be monitoring it and screening some of the kids. But despite the potential risks of methylphenidates, with appropriate cardiac monitoring, most kids can safely and effectively be treated for ADHD. So looking more at what people are actually doing then, knowing this risk and knowing that there's the recommendations, when we look at different medication use in kids with Down syndrome, so this was looking at just Down syndrome, not looking at the diagnoses for the children, we see this inverted V shape of increased use of stimulants in the sort of early school years and a decline through teen years. So people are prescribing stimulants, but again, we're looking anywhere from 3 to 15% of kids, again, much lower than the general, than the potential prevalence of ADHD in kids with Down syndrome. And we're seeing a variable pattern of what medications are trialed. The alpha adrenergic agonists are the other medications, so guanfacine would fall in this category of medications to treat ADHD. And we're also seeing a similar inverted V-shaped pattern where there's, but again, that's still at a rate much lower than what we would expect to be able to support ADHD in kids with Down syndrome. There's only one study that I could locate that was published looking at trialing medication for ADHD in kids with Down syndrome. They targeted guanfacine in 4 to 12-year-olds. They did not have a comparison group. But what they did see within that group of children with Down syndrome and ADHD was reduction in scores on the aberrant behavior checklist on both the hyperactivity, irritability, and the total score. So there are other reasons for why physicians may be reluctant to prescribe medication to kids with Down syndrome, and that would be because of their distinct neurophysiology. In kids with Down syndrome, what we see is that they have decreased dopamine and norepinephrine in their frontal cortex. Where methylphenidate increases those, we might actually see that the side effects or efficacy of methylphenidate in the kids could present differently. Further, kids with Down syndrome also have decreased dopamine beta hydroxylase and decreased monoamine oxidase. What this shows up at in terms of studies of mice is that when mice have those lower levels, the methylphenidate response is reduced. In children, typically developing children, also those that have lower monoamine oxidase also have reduced effects of that methylphenidate. So again, these findings altogether are suggestive that in kids with Down syndrome, the effect of methylphenidate might be reduced. More, in kids with Down syndrome, there's an increased catalomethyltransferase activity, which inactivates extracellular catecholamines. These are actually, the availability of those are increased when we take methylphenidate. So again, balancing that out, the efficacy could be different or attenuated in kids with Down syndrome when taking methylphenidate. This is further supported by children with other genotypes that predict high COMT activity, having a less robust response to methylphenidate. So again, further evidence that we might have a reduced response to methylphenidate in kids with Down syndrome. And even more distinct neurophysiology is that there's decreased mitochondrial respiratory chain complex 1 activity, which results in increased oxidative stress and decreased neural connections for kids with Down syndrome. And methylphenidate further impairs mitochondrial respiratory complex 1, which means that taking methylphenidate could actually worsen neurodegeneration and neurobehavioral functioning in kids with Down syndrome. So those lower rates of medication use in kids with Down syndrome, you know, there are some legitimate reasons for why physicians might be following those practices. So what do we need for research? We need clinical trials in kids with Down syndrome that examine the safety and efficacy of medication. We need to, kids with Down syndrome and ADHD, we need to address the concerns of cardiac safety, especially given the high incidence of congenital heart defect in this population, and also the distinct neurophysiology and how that might attenuate any responses. Really considering the impact of those comorbid conditions, so that whether or not they're controlled for in randomization, whether or not they're really screened for, and the diagnostic criteria for the inclusion criteria for those clinical trials. We really need to make sure that we're understanding how the comorbid conditions might be impacting our clinical trials. And then really focus on that differential response to medication and side effects. Are we having a reduced side effects? Do we need to start at a lower dose? Do we need to start at a higher dose? What are the side effects that we should be watching out for? Which ones should we be alert for in more detail? So these are some recommendations for what we can do for future clinical trials in Down syndrome and ADHD. And then here are my acknowledgements and my other colleagues who have helped me along the way, and also the community and the families.
Good morning, this is Mara Becker again, and I will be leading the protocol discussion for the guanfacine for hyperactivity in children with Down syndrome study. I have no significant conflicts of interest to disclose, but my time, of course, is supported in part by a number of grants, and this study particularly is funded by the NICHD through Task Order 6 through the Pediatric Trials Network. So just to refresh, this is the prospective therapeutic trial that we are developing to assess safety and efficacy of a therapeutic agent in children with Down syndrome. So the second component of what we are developing to work towards this clinical trial network for children with Down syndrome. And I'd really like to put a really huge shout out to the thought leaders who are from various different backgrounds, who have all worked with us tirelessly on this protocol, as well as our collaborators at MS and the leadership at Include and the DCRI, who have really all been so instrumental in developing this protocol. So thank you. So the title of our protocol is Guanfacine for Hyperactivity in Children with Down Syndrome, or what we like to call Hypo 1. It's a phase 2 study. Again, it's funded by the NICHD. And as Dr. Espenson mentioned prior to my talk, ADHD is kind of a big deal, right? So it's a common neurodevelopmental disorder of childhood. It's got a lot of short and long-term impact, and it occurs at a pretty impressive rate in children with Down syndrome. And unfortunately, those children actually have additional risks that are specific for this population. Now, the FDA has some approved medications to treat ADHD in children, but these studies, or these drugs, have been studied almost exclusively in neurotypically developing children. So there's really no specific labeling for children with intellectual disability, specifically in children with Down syndrome. Now, clinicians are using these medications, of course, off-label, as many of us do in pediatrics, but there's really no good data to drive dosing decisions. And I really believe, we all believe, that we can do better. So guanfacine extended release, or guanfacine ER, is labeled for the use in children ages 6 and greater. It's a non-stimulant medication, so different than the medications that Dr. Espenson had been talking about. It needs to be swallowed whole because it's extended release, which means there's less flexible dosing regimens. It's once a day. It only comes in 1 milligram increments of tablets. And there are a handful of studies in children with intellectual disability. Now, guanfacine immediate release, or guanfacine IR, is also commonly used in practice. And it may be used in practice even more because those are pills that can be split or can be crushed. So in children who have difficulty swallowing, it may be a better choice than a medicine that has to be swallowed whole. But you can imagine if people are splitting them or quartering them or crushing them, there's some imprecision in that dosing strategy. Doses can also be adjusted a little bit easier because it's usually dosed 2 or 3 times a day. So if a child were to become sleepy on that medicine, they could put a higher dose at nighttime, lower dose before school, and they're able to kind of fine tune or adjust that dosing strategy. And because it's also shorter acting, if they did have side effects, you could stop it a little bit, and you could stop it faster, and then the side effects would resolve even quicker. There are a handful of studies in children with intellectual disability, and one study, thank you, Dr. Capone, that was actually performed in children with Down syndrome on guanfacine. But there's really no pharmacokinetic or pharmacodynamic data in children with Down syndrome for either formulation, the extended release or the immediate release. So after a lot of conversation with our thought leaders, we decided that this was a therapeutic area we really wanted to delve into because it was a big problem and there were very little data to drive decisions. And so we opted to develop the following study objectives. Our primary objective is an efficacy objective, and we wanted to determine if guanfacine immediate release was efficacious for the treatment of hyperactivity, impulsivity, and inattention in children with Down syndrome after 10 weeks using the Aberrant Behavior Checklist Hyperactivity Subscale score. The secondary objective was a safety objective. We wanted to know what's the safety profile of guanfacine in children with Down syndrome. And our exploratory objectives were the PK/PD, or pharmacokinetic pharmacodynamic objectives, primarily understanding what's the guanfacine exposure in children with Down syndrome, how much drug actually gets in that body, how do we characterize the exposure of that drug with response, either in hyperactivity or inattention, as well as sleep quality. And lastly, we were really interested to know what's the concordance of the behavioral assessments when completed by parents compared to teachers. So we designed a prospective, multi-center, randomized, single-blind, placebo-controlled dose-escalating trial. So that means that it's we are developing a single-blind design, which means that patients and families do not know what they're getting, but the site actually does know. And that was intentional. We had originally thought about doing a double-blind design and went through that for quite some time. However, it was very difficult in light of the fact that this medicine needs to be escalated up to a treatment dose that's effective and then de-escalated or weaned off if you wanted to stop it. And we thought it was really unfair to put someone into a study and then not be able to necessarily continue that medicine when they were off of it because you'd be at risk for breaking blind. We also knew that from a safety perspective, it would be a little bit more reassuring for the site staff to be able to know what arm of the study that patient was in case they did have any side effects. We will need to enroll 72 participants, and that actually takes into account a 20% dropout rate. And those patients will be randomized 3-to-1 active drug to placebo. That means that 25% of the patients that are enrolled into the study will be on a sugar pill or on an inactive pill. And that the placebo is important to be able to truly show that that drug has an effect that is true. And that is, there's a degree of rigor to that, which the team felt was necessary. However, originally we thought we would randomize 1-to-1, but due to the fact that this medicine is used in normal clinical practice, it was actually feedback from some of our patients and families that said, I don't know if 1-to-1 randomization would be attractive to me as a parent. And so we talked a little bit about maybe shifting that to a 3-to-1 randomization so that in fact, 75% of those patients would get active drug and 25% would get placebo. We limited to ages 6 to 12 in patients who are affected with Down syndrome, and that was primarily under advisement by the PTN steering committee. It's just a well-known FDA age cohort to be able to assess. So we decided to limit it to that age range as well. So going into a little bit more detail for that primary efficacy objective, we like to look at the 10-week change from baseline in the ABC hyperactivity subscale. We chose that subscale because many of the studies, including that study by Dr. Capone in children with Down syndrome on guanfacine, used the ABC hyperactivity subscale. So it allowed us to look at how much of an effect size was seen in those previous studies in order to help guide the powering of this study. However, we know, as Dr. Espenson certainly knows, there are many other outcome measurement tools, behavioral assessment tools that we can use. And so we're also going to be collecting the Vanderbilt, the ADHD Rating Scale 5, the ABC Irritability Subscale, and the Nissinger Child Behavior Rating Form as well. Those will be secondary analysis outcomes because we don't really know which scale is going to work best, but we at least had some preliminary data to go on based on the ABC Hyperactivity Subscale. We will be looking at those secondary analysis endpoints at week 4 and at week 10. Our secondary objective will be looking at adverse events, serious adverse events, and events of special interest. And after lots of discussion, we developed these events of special interest to include clinically significant hypotension, which for children with Down syndrome is slightly different than neurotypical children, clinically significant bradycardia, any clinically significant cardiac events, so if there was syncope or someone blacked out, or any changes on the EKG or ECG, sleep disruption, suicidality, and clinically significant lethargy or treatment emergent somnolence. And so we are going to be measuring both the sleep disruption and the treatment emergent somnolence with some standardized assessment tools, which we'll talk about in a little bit. And the exploratory objectives, just to briefly overview, the first two are going to be PK/PD. So the first will characterize the exposure of the drug in this patient population. So utilizing samples we'd like to collect at week 4 and week 10 to get the amount of drug that is actually in the body, and using a POP PK approach, be able to help hopefully assess what some of those pharmacokinetic measurements are, like the steady state at the time of peak concentration, the minimum concentration or the apparent area under the concentration versus time curve, which all are little variables that help us understand how much drug is actually in the body. With the second aim, or the second exploratory aim, we will be looking at all of those exposure data in relation to outcome data. So how much drug in the body results in a good impact on those behavior scales, or a good impact in the sleep scales, or bad impact in the sleep scales. So looking at the exposure data in relation to outcome data. The third exploratory aim will be looking at the concordance, or how aligned or misaligned parent related behavior assessments are from teacher behavior assessments, because very little has been done in the Down syndrome space, and we thought it was a great opportunity to look at that. Okay, so this is our first audience poll question. I decided to throw a few of these in there just to get a little pulse about what y'all were thinking as we were presenting some of this information on the protocol. So my first question to the audience is, and you should be able to answer on your screen, how do you feel about the single blind design? Do you agree with us utilizing a single blind design for this trial? Yes or no? Okay, now we have one more question. My second question is, how do you agree with randomization of active drug to placebo in a 3-to-1 distribution? Does that resonate with you? Does that feel good to you? Or are you still not convinced that the placebo is a necessary part of this trial? Okay, last one. Do you agree with us utilizing the primary outcome measure for efficacy as the ABC hyperactivity scale? Now, you may or may not know the answer to this. You can just say yes if I convinced you or no if I didn't, and it's okay. We can talk about it at the end when we have some discussion time. But I just wanted to kind of gauge where people were at with some of these questions. All right, so bear with me for the next couple slides. I can't talk about the protocol without talking about inclusion and exclusion criteria, but they are a lot. And so I'm going to try to do a little bit of an overview and go as quickly as I can. So of course, in order to be included in the study, patients need to consent. And so that first is through consent. The second is that the patient has to have a clinical diagnosis of non-mosaic Down syndrome. And we were intentional on that after discussion with some of our thought leaders, to keep it as clearly delineated as possible. We are going to limit it to children who are between 6 and 12 years of age, including 6 to 12. Most importantly, we wanted children to have clinically significant symptoms of hyperactivity, inattention, and impulsivity. And so that means that they need to manifest a certain score, a minimum score on the Aberrant Behavior Hyperactivity Subscale, as well as the Clinical Global Impression Severity Score. And these have been used in previous trials in different populations of autism spectrum disorder, and we thought we would incorporate that as well, so that basically patients had to have clinically significant symptoms to be enrolled in the study. We also would like them to have any comorbid medical screening and clearance prior to being enrolled in the study. And of course, the participant has to be willing to participate. The exclusion criteria are extensive, and I'll try to go quickly. We'd like to exclude participants who've received guanfacine in the last 30 days, or if they've been on what we call concomitant medications or other medications in several of these subclasses. So stimulants, so we're trying to exclude patients who are currently on stimulants within the last 30 days, antidepressants, antipsychotics, or patients who are on strong, what we call cytochrome P3A4, which is a drug metabolizing enzyme, strong inducers or inhibitors, because guanfacine can interfere with that drug metabolizing enzyme. And we have listed examples of that in the protocol. If the patient is currently or plans to participate in another study, or they have known hypersensitivity to guanfacine, clearly they'd be excluded. If they've had a previous guanfacine treatment failure, if they've had a seizure in the last 6 months, or a change in their anticonvulsant or anti-seizure medicine dose in the last 4 weeks, they would be excluded. If they have a history of untreated severe obstructive sleep apnea or untreated thyroid disease, they would be excluded. If they've had significant hepatic impairment or known or pending renal failure, or any significant cardiac related conditions, and those cardiac related conditions are important. Maybe not as important as looking at it with mycophenolate, but we definitely wanted to rule out patients who had very significant bradycardia or low heart rate, any heart block, any hypotension, or a history of sudden cardiac death, or syncope or near syncope. If they have a pacemaker, they would need clearance. If they have congenital heart disease, they would need clearance by their cardiologist as well. Now, these are all things that clinicians kind of do on the fly, but we have to put them in very specifically in a clinical trial to ensure that those safety measures are put in place and that we're not enrolling kids into the study that might be at risk. And of course, if there's any other condition that the treating physician feels would warrant not being included in the study, that would count as well. So here is an example of the study procedures. Just to briefly say, it's the screening period from days 0 to -29, so up to 30 days prior to enrollment. We would get informed consent, demographics, medical history, physical exam, concomitant medications. We get a baseline EKG and some baseline labs to assess renal function and kidney function and liver function, etc. We'll also get some baseline behavioral assessments scores at that time. The day they get randomized, they'll be randomized to either active drug or placebo, and then they will go home and they will start on that medicine at the lowest dose. And every week they'll have a telephone assessment, which we're going to talk about in a minute, which will assess the safety of that medicine and determine whether it's safe for them to escalate to the next dosing regimen. At week 4, patients will come back in for an in-person assessment. They'll get their physical exam, their vital signs taken, an EKG done. We will ask for a PK sample drawn at that point, so a lab draw, and get their behavioral assessments completed. Then they'll go home again, and from weeks 5 through week 9, they'll get their weekly telephone assessment from their nurse or their clinical research coordinator, where they'll assess the safety, determine whether it's safe to escalate that drug with the treating physician, and then on week 10, come back in for another in-person assessment, which will be their final study visit, and they will have their EKG done, their PK lab draw done, their behavioral assessments, and a full physical exam. And then that's the end of the study after 10 weeks. So those telephone assessments will be done approximately weekly, just prior to the dose escalation. So this telephone assessment will determine whether it's safe to escalate to the next dosing strata. So we're going to provide a script to the nurse or to the research coordinator to use to assess the safety, including the events of special interest, and it'll determine if it's safe to proceed with that dose escalation. So we will utilize the Epworth Sleepiness Scale for children to assess lethargy. We will also assess suicidality if it's developmentally appropriate with standardized questions. We're going to be looking at sleep disruption, utilizing the Child Sleep Habits Questionnaire, the subscale specifically looking at waking during the night and morning waking. We're going to, and if there's any other finding that indicates it's not safe to dose escalate, that's certainly at the discretion of the treating physician or the PI. The dose escalation plan will look like this. So for children, we're stratifying it by weight. So children less than 25 kilograms will increase by increments of 0.25 milligrams approximately every week. And for children who are 25 kilograms or greater, they will escalate by 0.5 milligrams every week. And so we realize that dose escalation may not be pursued due to sedation. And so we have some halting rules included so that if the patient does happen to flag awareness with those screening questions every week, we have rules for the sites to be able to hold the dose at the current dose, reassess. If the symptoms are still there, consider readjusting, maybe tweaking the dose so that the higher doses at nighttime and the lower doses in the morning. And if the symptoms persist, consider going to the level below. So there are going to be some strict halting rules to help guide sites on the way to tweak those doses based on safety. We also, just so you know, because we're doing a placebo arm, we will be manufacturing capsules in smaller increments. So we will have 0.25 milligram capsules, 0.5 milligram capsules, and 1 milligram capsules. So we know exactly the dose that those patients are getting, which will allow us to also, to allow the clinicians to actually tweak those doses very specifically should they need to. All right, audience poll number 3. So question, is this dose escalation plan acceptable? And meaning every 5 to 7 days, assess, increase the dose. If symptoms are there, consider holding the dose or decreasing the dose. Number 2, most importantly, I think, especially for families or patients in the audience, is the blood draw at week 4 and week 10. So 2 different time points in those first 2.5 months. Is that acceptable? to get an understanding of how much drug is in that body to determine the relationship between the exposure and the outcomes. So in conclusion, I think just to sum it all up, this protocol that we have developed is a prospective, multi-center, randomized, single-blind, placebo-controlled dose escalating trial. It's 10 weeks in duration. We'd like to enroll 72 participants, and we'll be randomizing them 3 to 1. So 3 patients on active drug to 1 patient on placebo. And we will be dose escalating both the guanfacine and the placebo throughout the 10-week period. We'll be including children ages 6 to 12. We'll have weekly telephone assessments for safety and to help drive that dose escalation process. And we'd like to have 2 in-person visits to be able to accomplish the behavioral assessments, the EKG, the PK sample draw, and a physical exam just to assess safety along the way. Our plan is to request a pre-IND meeting with the FDA to discuss the protocol design and discuss utilizing supplemental PK data from the POP02 study that we're also participating in, as we've discussed, and to ask what additional data they would need to inform a label change for this indication in children with Down syndrome and ADHD. And I'd like to make a huge thank you to the team. It's been a really amazing experience with a lot of great experts weighing in, both from the clinical side as well as from the research side. I couldn't have done it without our collaborators, both the thought leaders, from the DCRI, from MS, of course, content experts that have been available for me to ask questions along the way, and of course the leadership from the NICHD and Include, who've also been participating and weighing in along the way as well. Thank you so much. I'm going to leave you with my email, but hopefully we'll have an opportunity to talk real time on our question and answer session. But certainly if you have any questions after the fact, please feel free to shoot me an email anytime. Thank you so much. Okay, hello everyone again. It's our live Q&A session at the end of this really awesome session. I'd like to introduce our speakers, and then I'm going to pass it off to Jenny Jackman, who will moderate you a break from my voice. First, I'd like to introduce Anna Espenson. She's an associate professor of pediatrics at Cincinnati Children's. She's also the research director of the Jane and Richard Thomas Center for Down Syndrome. And as you know, she did a great preparation for this discussion about her expertise in ADHD and Down syndrome. We have Ravinder Anand, who is the lead biostatistician of the MS Corporation, who we've been working with a lot as our data coordinating center as part of the PCN. We have Kylie Opel, who is a regulatory scientist at Duke University School of Medicine, who's been helping us to prepare our pre-IND request and is regulatory expert extraordinaire. And last but certainly not least is Jenny Jackman, who's the medical writing manager at the DCRI, and she has been really instrumental in our glue as getting our protocol prepared, and at least in this great drafted form. So I'm going to pass it to her to put the rest of us on the hot seat for a few minutes while we answer questions.
Thanks, Mara. So we have a couple of questions in the chat, but keep in mind as the panelists are responding to these questions, feel free to type additional questions and we can feed those in as we're discussing. So the first one is actually from Kathleen Egan during Anna's talk, so I'm going to give this to you. What are the recruitment mechanisms used by the research sites to attract and engage individuals with Down syndrome and families to participate in research?
Lots, but mostly relationships. So before we started doing research in kids with Down syndrome, we established relationships with the Down syndrome community. So I think building that trust was in the community was paramount to the success that we're having now. So now when we reach out through our local Down syndrome associations regionally and a little bit more broader in terms of like at least 2 hours away because of just the research requirements for us, there's already that trust built in. That we're going to buddy walks, that we're giving out information, that there's research, that's a thing, that we're also connecting to families in terms of giving out research information. So whether it's doing a presentation about what research is, or presenting about current research findings, or putting something out into a newsletter that they're putting, our local Down syndrome association is putting out. I think it's just building those relationships and talking about research and just giving and not just always expecting people to participate.
Awesome, thank you. Mara, do you have anything to add?
I think that you hit it right on the head, Anna. I think that just hearing how important those relationships really are and realizing as researchers, we don't just get, what do we give back? I think is the key to having a successful research project, but more importantly, having a research program, right? The ability to be able to partner with families and know what's important to them to help guide our questions, I think is really important. And I think the conversation about how to best relay that information back to folks throughout a study or after the study is something I think we have a lot of room to grow on and to improve upon.
Great, thank you both. So additional questions, shifting gears a little bit to the capsule preparation of the study drug for the trial. So this is a question from Tanya. Is the capsule filled with guanfacine or placebo powder so that families can open it, sprinkle it on food, or mix it with liquid? Also, who is manufacturing your capsule?
Yes, that's totally correct, Tanya. You are right on about that. So this was a really interesting process for me. We realized pretty early if we wanted to have a PK component to the study, we better know how much drug is actually getting in the body. And currently, because clinicians would half the tablets or quarter the tablets, it was fairly imprecise. So having what we call an over encapsulated formulation was key. So what we'll do is purchase the guanfacine immediate release, and then this pharmaceutical company, we're using University of Iowa, and then we're using University of Rochester to help package it and distribute it. They will fill these little baby capsules with powder, and we will both guanfacine or placebo, so you can open it and sprinkle it. I think that was the key that we knew was going to be definitely an important component we had to have available, because not every child, especially between the ages of 6 and 12, I certainly know some adults who still can't swallow tablets full. And so that was an important piece that we'd have to be able to do. So we will have to give some really strict, or at least structured kind of recommendations of what it can be mixed with, because as you can imagine, different foods might impact the way that medicine is absorbed, and that's going to matter in a study like this. But we should be able to allow that option for kids who can't swallow capsules full.
Great, thank you. The next question that came up is in regards to in-person visits. So I can answer the first part of it, which is when will the in-person visits be? So currently the protocol is written such that there's in-person visits at screening, week 4, week 10, and if there happens to be an early withdrawal or discontinuation, we would hope to get somebody in for an in-person visit then. And then the follow-up question to that from Joan is, how long do you anticipate clinic space being needed for these visits from a scheduling perspective?
Yeah, that's a great question, Joan, and I may have to tap you on that later on as we get closer. I think when you look at the study components of what we're going to try to accomplish, a lot of it is basic clinic stuff. So I'd say blood pressure, heart rate, vital signs, definitely at least heart and lung evaluation, an assessment of safety, and an EKG. And that was kind of part of the protocol that we thought was important as we are trying to establish the safety of this medicine. So there will be some time to that clinic visit that may be a little longer than a routine clinical visit that you would have if you were just monitoring someone after the initiation of that therapy. But I would say I'm going to probably rely on you and other clinicians to figure out what makes most sense for the timing of how long a session like that should last. I also think that we probably should be strategic and thoughtful about could we have some of the clinical assessment happen in the clinic and maybe the EKG or the PK blood draw drawn somewhere else. So it's not something that is going to tie up the clinic for excessive amount of time. But I think that will be determined a little bit later on down the road.
Great, thanks. And then next one comes from Emily. How can we get our local clinicians and specialists connected to all of this information so that Down syndrome communities across the country can be better served and informed?
I'll take this one. There's a couple things they can do. They can sign up for the professional portal from DS Connect that Sujata Bardhan talked about. because that will get them information about different studies or just resources that the DS Connect sends out in their newsletters. The other thing is to have them connect to DISMIG, the Down Syndrome Medical Interest Group, which is well, there's USA and there's also one for the UK, but the USA version is a bunch of medical providers and behavior providers. So not just MDs, but also your OTPT speech, psychologists who are sort of getting connected to share information, have a listserv, and also sharing information on their website. So those are the two things that I first think about for getting the providers linked. I'm sure there's others that I'm not thinking about.
Wonderful, thank you. Another follow-up question from Tanya regarding the capsules. So I'm gonna go to that while we're kind of still on that vein a little bit. Regarding the POP study, since we know the clinical doses are prescribed such that families often need to quarter or have the tablet, how will this uncertainty about the exact dose exposure be dealt with when analyzing the data?
Super good question, Tanya. I suspect, I thought about that myself. And I think that we will have plenty of kids who are going to be on round numbers of tablets. That's my hope, is that we were going to have kids who are on 1 milligram or 2 milligrams or 3 milligrams. That would be a little bit easier for us to identify that they're not quartered or halved. Although I'll be honest with you that it's going to be a potential limitation when you think about comparing them. But first, we have to see what we see. And primarily for the POP02 study, one of the main goals is to help us understand if the exposure in children with Down syndrome is similar to the exposure in children who don't have Down syndrome at those similar ages. And so I'd expect that the same thing we would have in young kids, as you and I have talked about, that those tablets are quartered or halved or crushed, would be seen whether kids have Down syndrome or not. And so part of this is just to understand, okay, can we make a reasonable assumption that the exposure of the medicine in the body is the same between children who have Down syndrome and those who do not. So that part hopefully will be the same in both groups. But I agree, for when we're trying to understand PK specifically, we may be limited at looking at those children who are on whole dosing regimens rather than those that split, just to be as careful as we can be.
And Jenny, I remember the other ones that the physicians can get connected to. Also try to connect them to Lumind IDSC, which is sort of an advocacy group trying to promote research, and also inform them about T21RS, so the Trisomy 21 Research Society, which is an international group of both basic and behavioral scientists. And so they also send out some quick newsletters about different research that's also looking more at the basic level of research.
Great, thank you. And speaking of other research, there was a question from Kathleen about what previous research was conducted to determine clinical readiness to give the medicine.
Anna, do you know this better than me? I'm not sure about the clinical readiness question in practice.
So it's one that we struggled with our study in terms of making sure that we could blind, because we're doing a double blind, the medication. So we went for a liquid form because we were trying to find something that was accessible to all children, but also to be able to be double blinded. So then that we thought would be a lot easier than trying to do any pill swallowing and any of that clinical readiness for pill swallowing.
Oh, so I was interpreting that a little bit differently. So that's
okay.
Interesting. I'm not totally sure, Kathleen, what your real intent was, but I was wondering how much we know as far as how significant of symptoms patients may need to exhibit in order to justify starting one of these medications. And I would say that probably a lot of this is based on the clinical features that children are exhibiting both at home and at school, and recognizing when is the right time to initiate, say, medication intervention rather than just behavioral intervention from an ADHD perspective. And I certainly lean on experts like Dr. Espenson to answer those questions. But I'm not sure there's been a ton of research to say when is it time to bite the bullet and try a medicine in a child with Down syndrome who's exhibiting those symptoms of hyperactivity. Do you have any of that info, Anna?
I don't get to prescribe medication, but as a person whose child is taking medication, I would say that it's when it's impacting the family. So if you're using behavioral strategies and you're able to cope and it's fine, great. If you're pulling your hair out, might be that's, it's starting to have that additional impairment on the functioning. If it's interfering with the child at school significantly, that's again, the impairment is going to be the important component.
Okay, so to follow up with that, Kathleen has just provided some clarification to her question. She actually wanted to know, were there studies on animals or others as kind of a scientific precedence to dosing in humans or clinical readiness in that sense?
There's tons of from the presentation, I didn't go into a lot of detail, but there's been a significant history of methylphenidate trials in kids with intellectual disability. And so I think that's where we're, both of us, both Mara and myself, are expanding upon that information, but just wanting to be a little bit more cautious because of the congenital heart defects.
Agreed. And I was going to say the same thing, Kathleen. There are a lot of maybe not randomized placebo-controlled trials of guanfacine in both children with and without intellectual disability. So there are definitely some studies. That's how guanfacine ER got labeled, at least for children. So there were definitely studies in humans after the animal phases, which are real early. So it's not like this is the, there are some data to inform clinicians to use these medicines in children. The challenge is they're not necessarily always in the patient population of interest. And so sometimes that is limiting in determining the right dose or the right strategy to start some of those meds in this specific population.
Great. So we're down to our last few minutes. So I wanted to touch a bit, come back to one of our poll questions actually about the single-blinded study design. So there have been some concerns about the single-blind design, and I wonder if Ravinder and Mara, you can speak to this a little bit. Can you give some insight? I know Mara discussed it in her presentation, but perhaps Ravinder, from a statistical perspective, in this design, why a single blind is in the current design?
Thanks, Jenny. I'll let Mara speak to the challenges from a clinical perspective, why we should go with single design. I mean, as a statistician, I would say, our goal is really to eliminate all bias. So we typically would go for a double-blind trial, but we also have to consider the limitation of a study and how effective we will be, to conduct the study, enroll participants, keep the participants safe, and keeping the whole aspects in mind, we look into what is the best design. We want to eliminate all biases in our final assessment of answering the question, does the treatment really work? Is it safe and efficacious? And in this case, we'll also do some PK analysis as well. And if you recall, in this study, the primary endpoint is being assessed by the parent, not the clinicians or study staff. So that made us feel comfortable that there will not be biases associated with the fact that the study team know what a patient received and in their assessment of the key endpoints of the study. So I'll give it to Mara to talk a little bit more about the clinical aspects of managing this treatment.
Sure, thanks, Ravinder. No, I totally agree, and I'm thankful that you brought up that point about that primary outcome measure, which was important in some of our conversations. And as I didn't allude to in great detail, but I mean, this was a discussion we had a lot with the top leaders, a lot with our statistical team, back and forth quite a bit. And so I think what it boiled down to for me, Jenny, is that it was hard for me to not break blind at some point, so that families didn't have to, after escalating up to hopefully a drug dosage that was effective, then come off of it in order for them to be able to be moved onto the commercial product. I thought that would be a really hard sell. It'd be a hard sell for me to enroll my child into a study where I might be, even a treatment that was effective and then have to come off of it in order to maintain the blind. And so that was a real fatal challenge for me to kind of wrap my head around and get over. And so then we tried to explore, well, is there an opportunity that we can do an extension period of 10 weeks where everyone would get active drug in a blinded fashion, which then prolonged the study and really ended up being quite challenging to do in a feasible manner where the kids wouldn't have to have more than 2 capsules twice a day, which for some is still already a lot. And we thought that that would be really excessive for families to do, and also potentially maybe prohibitive from a cost perspective, because we'd have to manufacture a lot of different dosages of capsules and a lot of different dosages of placebo. And so after all of that, and recognizing that the primary outcome measure was actually a parent measurement, and it wasn't a physician or clinician guided tool, that we thought maybe the single blind design might actually be reasonable to consider. And to that point, and we didn't really get a chance to touch on this, but I may ask for a couple extra minutes for Kylie to speak about the FDA process. We figured we would design it in a single blind fashion and then ask the FDA how they felt about that. Is that acceptable to them? And I think in this process, as we're trying to understand what's the most effective protocol design and something that is hopefully impactful from a labeling perspective, the FDA's input is going to be really critical. And so we wanted to, just make a decision and pitch it to the FDA and see what they had to say on it. But Kylie, do you want to give a few words about that process for people so that everybody knows a little bit about it?
Sure, I'm happy to. Thank you, Mara. So with what we're doing is we're submitting a meeting request and a pre-IND to FDA. So this enables us to present essentially our story, our justification, and we typically submit our protocols as well. So we give FDA the full background of how we've approached this, where we're coming from, why we want to do this study, which has been especially important, I think, with this study. And then we're able to ask the FDA questions. And we've honed our skills over time and working on how we ask our questions, and we try to be, even within our questions, we provide a lot of background. We always give our justification of why, this is what we think is the most appropriate approach, and ask the FDA, point blank if they agree on some of our, the different questions we have. With this one, it's been very out of the box. It's been a lot of fun and really exciting. We're learning a lot as we go, and we have a lot of questions for the agency. So we'll submit this to the agency. They'll come back typically before we have a meeting. In this case, we're going to have a face-to-face meeting. We'll do a video conference, most likely, because I doubt we'll be able to do face-to-face in person when we have the meeting, but we'll receive preliminary feedback from FDA where hopefully they'll be able to go through most of our questions and in writing respond to the questions that we have. So then when we actually meet with the agency, we're down to just a few questions that really need that dialogue. And I think, especially with this one, it's that dialogue that's going to be very important. As much as we can put in writing, it's also very helpful to actually have the conversation with FDA. And with the pediatric trials work, I think we've been really lucky. Dr. Zimmerman talked about a little bit with the relationship that we have had established, with the regulators, with the FDA. And we get a lot of feedback from these meetings that really direct how we design our studies so that we know when we submit our IND application that we have kind of FDA's buy-in and input on what we're doing ahead of time.
Thank you so much, Kylie. So I'm going to wrap this up. Thank you so much to all of our panelists. Thank you for all of you who asked questions, and Mara graciously provided her email. So if you have any follow-up questions, I'll go ahead and say, why don't you email her? And I'm going to put you back in the hot seat, Mara, to finish us up. Thank you so much.
Thanks, Jenny, and thank you guys so much. And I'm really grateful for all the questions. I was kind of worried it was going to be crickets. So thank you so much for asking all the questions. That's exactly what we were hoping for, to get some engagement and discussion around this draft protocol and to see how it flew with folks. So I appreciate it. I'm going to be wrapping up next. So I'm going to pull up some slides on Zoom. So if you could just hold tight, we'll finish up this meeting and give you next steps as we move forward. Thanks. I'd like to spend just a few minutes to wrap up and talk a little bit about next steps. and hopefully get everybody on their way not too late from a long and exciting morning. So, and our immediate next steps I wanted to highlight just to make sure everybody understood where we were going. And the first is really to continue our site activation process and participant recruitment into POP02. So as Elena mentioned, this has been really fun and cool to kind of expand this already pragmatic protocol into our population of individuals with Down syndrome. And as she mentioned, and kind of fortuitously, we chose to have our first drug of interest to be guanfacine. And that's kind of a reason, right? We want to be able to utilize any samples that we're able to collect in children who are taking guanfacine as standard of care to be able to help inform us in our prospective protocol that we're creating. Our goal is to get our first patient enrolled into the POP02 component by the end of the year. And so I'm putting my money on Duke and Children's Mercy, who are both, one being activated and the second nearly activated, to hopefully identify a patient with Down syndrome coming to their clinic that might already be on this medicine, that might be willing to be enrolled in the study. And we're excited to get that going. The second is that we want to make sure these resources, this meeting, any of the resources that if any of you guys have been perusing, have been created by a number of our thought leaders, and opinions about research in Down syndrome available on the PTN website. So that has actually been done. Thank you to Megan Daly, who put up a site link, which I'll show you in a future slide. We also have been talking about consent and assent templates, and I think a lot of conversation on this call has been talking about resources that we can use to really help our individuals with Down syndrome and their families understand step by step what's going to happen. And I think that this is a wonderful place to be able to store some of these tools that we can share with other institutions and organizations that are trying to further research in this population. As Kylie mentioned, our plan is to submit this pre-IND request to the FDA. And this is a really important piece, and it's kind of a big deal, because if we have that feedback from the FDA, understanding what parts of our protocol they are in agreement with and what parts they would like us to reconsider, that really helps us to fine-tune what this protocol really looks like. And most importantly, we're trying to also push the idea that in some cases, especially as you listen to Dr. Kishnani's talk, there are some medications that really should have, or we should consider putting a special detail about individuals with Down syndrome on the label. And understanding if the FDA agrees with this notion or not, I think is important. But most importantly, we need to bring it up for discussion. Eventually and soon, hopefully, we will finalize our protocol and determine participating sites for this protocol. So if you happen to be a PTN site listening today and you're interested in being part of this randomized clinical trial, once we have it finalized, please keep us in mind and reach out. I would love to hear from you, because I do think we will need several sites in order to reach our sample size of 72 children. And lastly, we will be sending a survey meeting evaluation emailed out to all participants. And please fill it out, especially for those of you who want to claim CME or MOC credit. Having that evaluation will help us finish that last step. Things to consider, I hope to kind of pique your interest to think about either responding in the chat or responding by email, would be how we can better engage additional PTN sites into this work. How can we reach even those sites that are not PTN sites to get involved in this work? And luckily, I've been able to have conversations with folks both in and outside of the network who are just interested in this domain, in part because of the work we've done with the Include project and some of the work groups that I've been part of, and been so fortunate to meet people in this space. But I think communication and community is actually a really big part of this. You see so many different stakeholders from different domains and different subspecialties that are all interested in furthering this work. And so how do we do a better job kind of bringing everybody into the fold? Are there any additional types of programs for this type of bidirectional education that might be helpful? I'd love to hear your feedback on this approach that we took, and hear any other suggestions that you may have that might be more useful moving forward. And also a little bit more about how people would feel, or how they'd like to receive feedback or updates on this work. Do people want to have an ongoing a listserv, or access the PTN website? And feel free to just shoot some ideas into the chat box while you're in it, or send an email to me after the fact. But I think the feedback and the communication we've had thus far today has been so rich. I'd love to continue that dialogue. Here are a number of resources for you to consider as you're looking through. So there's the PTN website, of course, which is fairly general, but then Megan Daly was also able to give us our direct link to a number of the flyers and the videos that a number of our thought leaders and patient advocates have participated in creating, which are awesome. We have the Down syndrome PTM specific email to reach out to us. And of course, just don't forget, this whole meeting is recorded and you'll be able to access it and listen to it. Thankfully for me too, because I've probably heard about 2/3 of it, but some of it has been in and out. I would love to be able to listen to that after the fact, and a number of the materials will remain on that website. Any of those questions that we weren't able to get to, we will happily answer and respond back to the whole group after the meeting is completed. For physicians who would like to claim MOC Part 2 credit, I started to see some comments coming in through the chat, but please, please just send me an example in the chat of any practice change that you might be willing to consider to employ so that we can provide you MOC Part 2 credit just for the meeting attendance itself. That's kind of an important piece. So we will be collecting the folks who want to claim credit, but it'll be important if we can see some feedback in the chat box about practice changes that you guys would be willing to employ. So please, right now, before you sign off, throw in a few suggestions for us to be able to include back to the ABP. Any questions or interest in participating, please, please, here's our email. Hopefully you'll use it. We look forward to hearing from all of you. This has been just an awesome way to start our week. And most importantly, I've got a number of thank yous. So I can't even tell you how much the team of individuals that have been putting not only the protocol together, but this whole conceptual framework about how we can further clinical research and trials specifically in children affected with Down syndrome. And I think that the challenges that we face are like real, and we've been highlighting a number of them, but so many great opportunities to improve it, and so many strategies that have been talked about today about ways that we have been able to include these individuals and their advocates into this planning process. I'd like to thank the thought leaders specifically who have been tirelessly meeting with me every month in this work, DCR collaborators, which have been pretty extensive, both on the PTN site activation site, but also on the regulatory site, and our site PIs who have all been active, engaged members of this work. Emmis has been terrific. I've learned a ton. I think Gina and Ravender are probably tired of me by now, but we have a call right after this meeting, so you're not done with me yet. A number of the content experts like Anna, who's also been willing to be part of this, and Tanya, who always asks great questions. Include leadership and NICHD leadership, particularly for your support through this process and continuing to have faith in us to complete this mission. And of course, Hannah, you have been a wonderful therapist for us through this process, getting this meeting domain under wraps and under control. And I really appreciate you shepherding us through this process. But I think everybody can probably agree that this meeting would not have been nearly as cool or as impactful if we didn't have the advocates and their families with them. This was pretty awesome. And I really think that we have brought to light a number of really great thoughts and suggestions that I look forward to sharing and hopefully learning from and growing from and making research better in this community in the time we have left on this planet. So thank you so much for all of your commitment and your interest and your engagement in this work and being willing to spend your morning with us and to help us be better. Last thank you, because without Elena and Jalila, this meeting would not have happened, because they are remarkable in their efforts to be able to pull this virtual meeting off. And I appreciate their flexibility in changing from in-person to virtual, and their tenacity in getting everybody set up and organized. And without you, this never would have happened. So the ultimate in thanks. And last but not least, you're not getting out of this day without a reminder to vote. Okay, super important. Get out there. If you haven't done it already, go vote. And I'll tell you, we could have come out of this meeting a little bit overwhelmed and dejected, but instead I'm really energized about it. And so I'm even more excited about getting you all out there to the polls tomorrow. Don't forget your opportunity to vote and go do it. And thank you very much for attending, everybody. I really appreciate your time and your investment in this work. And I look forward to this just being the beginning. Thanks very much. Bye-bye.